afternoon, everybody, and welcome to our second session of Partnering with Our Patients and Families. We had a wonderful session this morning, and we know that we will have at least as good, if not exceed the expectations for this afternoon. My name is Mary Lynn McMaster, and I have the pleasure and the honor of facilitating the session this afternoon, along with Marla Rosen, a patient experience specialist at Kingston General Hospital. I made that same mistake this morning too, and I'm from North York and Marlon is from Kingston, and my role will be to facilitate. Marla's role is going to be as the raconteur, and that which will be documenting our journey this afternoon over the next 90 minutes. So what we will do this afternoon is in three parts. The first part is we are going to have the speakers from Georgia, Bernard and Rosalind, and you all are going to hear a great presentation on patient and family-centered care and the journey that they have been undertaking over the last 20 years. And it is a journey, not a destination, and they will help us understand that. The next thing we will do is we will break into groups, and that's probably going to be about eight to 10 tables, and there are 4 questions that we're going to ask you to consider. So you had questions this morning in the groups that you were in, and so it's the same sort of questions this afternoon, only around patient and family-centered care. And the questions are going to be, what do you like about the principles of patient and family-centered care, the principles of respect and dignity, the principle of information sharing, collaboration, and participation? Tell us about a positive patient experience that you've had regarding patient and family-centered care, and it's all about the power of the stories. And this morning we had some very powerful stories that were shared with us and the learning from those stories. What do you see as the challenges regarding patient and family-centered care? And for those of us who are new to the journey, we need to learn about those challenges. And for those who have been on the journey for a number of years, it's an opportunity for you to share those challenges with us and have discussions about that. And then what are the strategies that have been implemented? And the strategies for those new on the journey, and the strategies, again, for those who have been on it for a number of years. So before we get started, I'd like to know, how many patient advisors are there in this room? Okay, we've got about a half a dozen. That's great. And we had about a half a dozen this morning. And there's a really opportunity, because they're dispersed throughout some of the tables, to learn from there and really engage the conversation with that. I assume the rest of you work with community agencies or in hospitals. Anybody outside of a community agency or a hospital? Okay, great. How many of you are new to the journey of patient and family-centered care? So you're here as a learner. Okay, so a few of you. Some learners down here that I know. It's a really good opportunity for us as learners to learn from the teachers, and the teachers who've been doing it for a while. So how many are teachers here? And you've been on the journey for a number of years? Great. Again, some disbursement throughout the room, and we look for your knowledge and your expertise and the opportunities that we can learn from you. What have been the challenges? What have been the barriers? But what have really been the successes? And you can engage us in those conversations. So what we'll do is Bernard and Rosalind will speak for approximately 20 minutes, and they're going to, as I said, share their journey. We're going to break into the groups, and for 30 minutes we're going to have you discuss those questions. And that we ask that you identify somebody within your team who will be a recorder, and then somebody who will report back on it, because we will report back on the 4 questions. And then we will come together and we will do 30 minutes of report back. We learned this morning that there was more information that people wanted to share, and such that we ran out of time. So we will spend some more time this afternoon doing some sharing, and then there will be a break, and then we'll come back to the plenary sessions. Before I introduce Marla, who will introduce the speakers, any questions about this afternoon? Okay, great. Well, it's my pleasure to introduce Marla Rosen, Patient Experience Advisor at North York.
No. Hi, my name is Marla Rosen, and I am from KGH Hospital. I am a patient experience advisor at the KGH Hospital. I have the privilege today to introduce you to Rosalind Marshall and Bernard Robertson from the Georgia Regency Health in Augusta, Georgia. I actually had a chance to visit there. It's an amazing hospital, great experience, and I came totally inspired and gung-ho, and I hope today you enjoy.
Good afternoon, everybody.
Good afternoon.
All right. I am Bernard Robertson. I'm the Administrative Director for Patient and Family Centered Care at Georgia Regents Health System.
And I'm Rosalind Marshall, Nurse Manager of Neuroscience Service Line at Georgia Regents Health System in Augusta, Georgia.
So we have come to talk to you this morning about our journey and to also create this knowledge exchange that has been doing so great. This has been a great conference. So it's been doing so great here, and people have been exchanging knowledge. But the first thing we want to do is we want to get you to stand up because I want to get rid of that lunch for you before we get started. Now, there are some people who have participated in this exercise. But those who haven't, I will tell you, if you have trouble walking, chewing gum and walking, laying in the bed, chewing gum and laying in the bed, or just spitting and walking, please do not try this. So I want you to raise your hands in the air, and I just want you to just shake it up, and you're at a Maple Leaf game or Blue Jays game, and you're ready to go. All right. And so then I want you to throw a little mix in and just kind of kick that leg behind the left leg behind the right leg. Woo. And I want you to stand there and I want you to yell out what you feel. Unsteady, silly, unsure, what else? Embarrassed, what else? Unsteady, all right. Thank you all. And the reason I wanted you to do that is because those are the kinds of things we hear from patients and families. When they come into our offices or when they're in our hospitals and we are there, they don't feel like they get everything. They feel unsteady. They feel, embarrassed, because sometimes we don't give them time to ask questions or they don't feel they can ask questions. So there are a lot of things that patients and families feel that I want you to feel today as we speak through this, and I want you to think about how you can make it better. And one of the things I want you to pay close attention to is the 4 principles of patient and family-centered care: dignity and respect, information sharing, participation and collaboration, because that's going to be the foundation for everything that you do. So now, our journey, about 20 years ago, a group of parents, they voiced their concern because of the way they felt we were treating them. They said, it really matters how you treat me. We know that our children are getting great care, but it matters that you will only let me back there for 15 minutes each hour to visit my child. So therefore, we have taken the control from them. They have no say-so. We've adopted their kids and they didn't get to sign off on it. So they wanted to talk about this. They wanted to make sure that their voice was being heard. We had all kinds of barriers there. That 15 minutes, we had a coffee pot that was there that had a big sign on it that says, for staff only, no parents allowed. We wouldn't even give them coffee. And so they were concerned about that. And so we had a wonderful, wonderful champion. Her name was Pat Sadamka. And we lost Pat about 3 years ago. Pat was our champion. She was the champion for patients and families. She really listened to what our patients and families' concerns were. And Pat brokered a meeting with the physicians and the nurses and the parents to talk about what the issues were. And she brought them together. She started collaborating with them and looking at what their concerns were. And actually, they were able to sit down and work those issues out. And that was a great thing because that started patient and family-centered care in our organization. We had a lot of wonderful parents who were a part of it, who really made our organization great by the work that they were doing. Julie Moretz, who is with the Institute for Patient and Family-Centered Care, she was one of the vocal parents who really helped us to see, how we were treating our parents. And so that was important. So from there, we developed a family advisory council, and even from that family advisory council arose a children's advisory council, which we call Kids Art. And the children actually get a chance to voice their concerns. Their concerns are truly just as important as the parents. And when we were building our new children's hospital and we were in the planning, we had those parents and those children as a part of the planning who actually made a great design, who had wonderful flow. they made it wonderful. I mean, they really made it wonderful. I can't use that word enough. They really made things flow for both faculty and staff and for patients and families. And so if you ever came to our organization, you would see we have a McDonald's. You know that had to be kids, you know? But what we found out here in years past is not necessarily the kids that's using it. It's the highest grossing McDonald's in our area, and we found it's the faculty and staff. So we have a McDonald's, and we looked at everything. We have a food taste test with the children. They're telling us about what it is that they would like to eat. And so we find alternatives for those things. And so by listening to those parents and listening to those children, we were able to transition from the Children's Medical Center to the Adult Medical Center, the things that we learned. And that's when we were able to go to Rosalind Marshall's unit.
Okay, you have arrived at Rosalind Marshall's unit. Back in 2003, I was living in my own little world. I had been a nurse manager at the hospital for about 15 years, and the CNO said, well, you know, we don't have a nurse manager in the neuro unit right now. Can you please just pick up the neuro unit for 6 months and we'll hire someone? Well, that was many years ago, and I'm still on the neuro unit. So don't believe it when they say it's just an interim thing. So, but anyway, I love it. I love it. So when I took on the unit, we had our patient satisfaction was at the 10th percentile. The turnover rate was tremendous. I mean, nurses were coming and going out of the door. We also had the higher levels of falls, a high level of use of restraints, medication errors going on, and just no consistency in the care. So when Pat Sadomka approached me about moving patient and family centered care to the neuro ICU, I'm thinking, okay, we're gonna start this in an ICU unit, not even on the med surg unit. I said, okay, I'm up for the task. I'm always up for a challenge. Anybody that knows me, if you tell me I can't do something, I'm ready. Bring it on. I'm going to do it. So that's what we did. I didn't know where I was going, but the journey has been fabulous. We moved from the 10th percentile to the 99th percentile in patient satisfaction. Right now, the staff that was there in 2003, they're still there. So we don't have any vacancies. We've had a 62% reduction in medication errors, and that's all from getting the families actively involved, the patients and families actively involved in everything that we do. And I tell you, I cannot stand here and tell you there won't be obstacles and barriers when you move forward with patient and family-centered care. A lot of the staff was resistant to change. Have you heard that before? A lot of, especially the ICU staff, you know, they want to be in control. You know, the ICU nurses always want to be in control. You got 15 minutes and you got to get out of here, right? So what we did, we had the opportunity also to make some changes within our physical environment of the unit. You don't have to have a renovation to do patient and family centered care. Let me just say that, okay? But we had the opportunity at that time to make some changes. So what we did was we took down the doors to the ICU. There is no buzzer to ring to come in anymore. You don't have to wait for anything. What are you waiting for? You don't have to wait to find out what's going on with your loved one. Now there's an opportunity to be there. It's your choice. We put sleep sofas in each one of the ICU rooms. We put a recliner there. They're there. So when the physicians come to do rounds, guess who's giving the report? Tell me. Who's giving the report? The families. They're giving the report because who knows that patient better? That family member. They'll finding errors with patient medication. You know, a lot of the times we change medication schedules in the hospital because that's the way we want to give the patient medicines, right? What are they going to do when they go home? They're going to change it to a time that's more convenient to them. So we work with the families with medication administration while they're there. Our unit-based pharmacist is very active in helping us with medication administration and medication reconciliation. But I guess the most important part here in the whole story is that no matter what we did in transforming our unit, we didn't do anything without the patients and families, from picking out paint colors, picking out furniture. I mean, the patients actually got in the hospital beds, laid in the beds, played with all the controls, picked out furniture. At first, we picked out furniture that was very hard. I mean, it was very, very hard furniture. It didn't really work. But having the patients, I mean, they're the ones that's actually using it, right? Right? Okay, are you with me? I'm not, okay. I am in Canada, right? Okay. All right. They're the ones actually using the equipment, so they should be the ones to help you to select what works best. So partnering with your patients and families is not just about looking at family presence. It's about every aspect of care. I mean, it could be from IT. We also moved to a PFCC app that we have at our institution too. That's on iTunes. You can look at it if you get a chance and download it on your iPhone, your smartphone.
It's free.
It's free. Just to inform the patients and families and the community about PFCC. We've moved to an environment. I'm not gonna leave you some minutes. Okay. We moved to an environment that is not just me being the one that's moving patient and family-centered care forward. It's also the staff. They have become empowered with patient and family-centered care that now they're even moving out into the community, educating the community with our patient advisors on different things. So patient and family-centered care is not just for the patient. There are a lot of benefits to the staff as well.
So for those of you who are sitting out there thinking, you know, well, this sounds like it's only for clinical staff. Well, it's not just clinical staff. It's also non-clinical. There are lots of folks out here. We probably got some facilities people. We got some environmental service folks. We've got some admin folks out there. You know, we have many disciplines out there that are not clinical. And what we have found is we've had to educate them on where they fit in this scheme of patient and family-centered care. And once they do, you see the light bulb go off. You know, once they've had training about patient and family-centered care, they go back and they look at, you know, what their practice has been, and it's like that's where it is. You know, environmental services, you know, our environmental services people, they give us just as much information, sometimes as the family, because you know what? Environmental services folks, when they go into the rooms of patients, they go in there and they actually talk to the patients. They don't just go in and clean the room. And they go in, they get to know the patient, they get to know the families. And I will tell you, they can bring information back to you. You know, we've had in environmental services when I was with Rosalind's unit, and I guess that's why we work so well together. But when I was with Rosalind's unit, you know, I had an environmental services employee to come to me after I had gone into a patient's room to talk about discharge. And the young lady, she said, well, I'm going home with my daughter. Well, okay, you know, I write that down. I'm doing my psychosocial, I'm getting all the information I need, and then I leave the room, and the environmental services employee comes out and she says, well, Bernard, she didn't tell you everything. You know, she's not going home with her daughter. She told you what you needed to hear so she could go home. And so I had to go back in there and talk with her. And I actually took the environmental services employee with me, and she said, well, now you need to tell him everything. Well, I guess I'm gonna have to talk to him. You done told him. So, you know, it's those kind of things you gotta look at. You know, you've gotta value all employees, because guess what? Every employee in your organization has a piece to do with patient and family-centered care. It is not just nursing. It's not just the physicians. It's everyone. And so when you're looking at spreading patient and family-centered care throughout your organization, you have to look at every aspect. So if you're wondering where you should put it and when you should invite patients and families to be a part of it, just think everywhere. It's easy. You know, you heard Dave say, ePatient Dave say, you know, I got my marketing piece is, you know, ePatient Dave. You know, I got it in as my Twitter account. I got it as my email. I got it as my Facebook. Well, think about patient and family-centered care and where you put it everywhere. Just think everywhere. Anytime that you got to think about it, patient and family should be there. So we want to make sure those things happen. We have patients and families that help us do interviews. When I was interviewed for my position, guess what? I interviewed with about 8 patient and family advisors, and it was tough. They are tough because they ask those questions that we don't normally ask. We want to know What's your 5-year plan? What's your 10-year plan? You know, where'd you work before you come here? You know, those kind of things. They want to know, how do you feel about me being at the bedside with you? Or how do you feel, Bernard, about me coming in your office every day and talking to you about things that I found wrong in the organization? And how are you going to help me fix it? They want to know those important questions. But not just talk to you about it. They want to be there to help you to solve it. And that is the one thing that I've loved about working with our patient advisors. And that's one of the things I love about patient and family-centered care, is because I get to see the transformation. I get to work with the patients and the families to make that transformation happen. I get to work with the staff, you know, to make sure that it is incorporated in everything that we do. So we want to make sure that when you talk about patient and family-centered care, when you're looking at where you're going to put patient advisors, you know, and why you should have them there, you think everywhere, but you also think about what? The 4 principles. It's dignity and respect. It's information sharing. It's participation. It's collaboration. That should pop in your mind every time you talk about patient and family-centered care, every time you talk about patient advisors. When you're looking at doing other things, when you're looking at your service recovery, when you're looking at your service excellence, it should be based on the 4 principles of patient and family-centered care. And those are the kinds of things that's going to make your program great. I will tell you, you will find those barriers, and they'll pop up often if you don't base your programs, your philosophy of care, your practice on those 4 principles.
I wanted to go back and add that, you know, a lot of times staff will be resistant to change. And I can remember when we started with bedside shift report. How many of you are doing bedside shift report? Okay. When we started with bedside shift report, the nurses said to us, we can't do that. That's going to take too long. They're going to ask too many questions, and it's just too much. But throughout the process and working with our patient advisors, we found that bedside shift report actually saved them time. I actually found out a lot of things they were saying in our report, sitting at the table, didn't need to be said. They would have had those little extra conversations about what are you going to do Saturday night? Can you meet me so-and-so? All those little conversations were gone. And the conversation that really needed to occur about patient care was happening at the bedside, and it took less time, and they were more meaningful because who was involved in the care? The ongoing nurse, oncoming nurse, the outgoing nurse, and the patient. Imagine that. Including the patient, it's their care. They're there to receive care. The patient and the family. I always tell my staff, we are visitors in the lives of the patients. When they leave us, they're going back home with their loved ones. And the loved ones are going to be the ones that are going to be providing care. So we want them involved in every aspect. Setting those goals for the day. Working with the patients and families, setting goals for the day during bedside shift report. Doing that hourly rounding. Doing those discharge callbacks. Discharge callbacks are not only meaningful to us as caregivers to let us know how we're doing, but to ensure that the patient is home and that they're home in a safe environment, that they're taking their medications correctly, that they even bought their medications. That's one of the things we found when doing discharge callbacks is that some of the patients didn't even buy their medications because they couldn't afford it. So now our unit-based pharmacy pharmacists work with the patients before discharge to call around and find the places that have medications at a better price. So these are the kind of things you learn by collaborating and partnering with your patients and families.
So I noticed that there were quite a few of you out there that are just now starting the journey. And you're probably wondering, where do I start? How do I do that? Well, you know, what is it supposed to look like? How do I get patient advisors? Well, I'll tell you, we have a large patient advisory group in our hospital. We have 5 institutional level advisory councils and then about 32 program level advisory council. And we have patient advisors in just every committee you can think of in the organization, including members that sit on our board and some of our board level committees. And I will tell you, you want to start with talking to staff about patients or family members who have had an experience in their area. And you want to talk to them about becoming a patient advisor for your area. And you work with and some of you may not already have folks that actually coordinate those. But you want to start to get those names. You want to start to talk to families about what it is to be a patient advisor and why would you like to have them in your areas. Some of you may be sitting there thinking, you know, I'm never going to be able to do all of this. I'm going to tell you, it's easy. It doesn't cost you a whole lot of money, you know, and it's that kind of thing that it's the right thing to do. As long as you make sure you use the 4 principles: dignity and respect, information sharing, participation, and collaboration, your programs will develop. And I tell you, you will have a great basis for moving it even further.
As I was saying that we moved it to the neuroscience unit, now a lot of people say, well, you did some renovations, that's why you had the improvements. You know, you got the new chairs, you got the sleep sofas, you know, you've done all the right things, so that's why your patient satisfaction improved. So what we did was move it throughout the whole facility, and we started to see the same results on the same units that didn't have any renovations done to them. So that just proved to administration and to leadership and to the staff, the frontline staff, that it's not about those big things, it's about the little things. Partnering with your patients and families, no matter, at all levels, no matter what you're doing, and that's what works.
So, in closing, my suggestion is, if you're thinking about when do you start yesterday. It's something that's easy to get going, and you don't have to put a whole lot of thought into doing the right thing. We all know what the right thing is. You don't have to put a whole lot of thought in doing the right thing. You don't have to start out big. You just need to start, okay? Thank you.
Thank you, Bernard and Rosalind. And you know, their advice is so right, and this advice we had from Kingston General is don't overthink it, just do it. And just make it happen. And you know what? That's what we did, and that's what happened, and it's very successful. So that's what we're going to do this afternoon. We're just going to do it. We're going to have some great conversations over the next 30 minutes about the implementation of patient family-centered care at organizations. And that. So we'll spend 30 minutes doing that, going through the 4 questions. You were all in the sessions this morning, so it's the same format this afternoon. I won't go through all of those details. Again, if there's some small tables, please feel free to join other tables to make larger groups. And in 30 minutes, we'll come back together. We'll look for people to report back, to share some stories and share some learning. So let's all get it underway, and let's just do it.
Adults think they can read our other adults. The definition that we were looking at, they're called flow boards.
Have you had a good time discussing at your tables? It sounds like there's been lots of really fascinating discussions going on. So we're now going to have the opportunity over the next 20 minutes to share that discussion. And we'll spend approximately 5 minutes on each question. And so it won't give us, as I said earlier, it's not an opportunity to share at all of the tables, but we'll try to get to each of the tables at least once.
At our table, we actually looked at all the questions from a patient lens and from a caregiver lens. And we're fortunate enough that we do have a patient advisor at the table, so that made that a little
Yeah, you've got Glenn
easier.
over there.
We have Glenn over here, so we have that advantage. So from a caregiver perspective, the principles sort of enable the team to ensure what they're doing is really what the patient wants. It validates what we're providing. From a patient perspective, it makes them feel included. It gives a sense of respect and dignity. And they have a lot of knowledge that we don't have as care providers that then get put on the table and can be very insightful and very informative and could change the course of the care as a team. So it's very empowering for the patient and family, but I would argue it's also very empowering to the team. We've got lots more if you want me to cover more.
Okay, so one more.
One more. I think it builds trust between the family and patient and the team as well, because everything is transparent and shared. So that's the other really important principle.
The security guard then went above and beyond even further, met them the next morning, ensured that they got to where they were supposed to be going on time, and just None of the upper management knew of this situation, and family wrote back a few days later, and just shows the example of taking that extra step and going above and beyond your designated duty. Just makes patient and family-centered care that much more valuable.
And he said every time he visited her, anytime he mentioned her cat's name, her face would just light up. So he called in, he wanted to bring the cat in to see her. I just spoke with the charge nurse. She said he just needs to let us know exactly when he's going to bring it. He had the cat in that day. He said the smile on her face when he brought the cat in was just, brought tears to his eyes, and the family was so grateful.
This isn't my story, but it was somebody's at the table that I thought was very powerful. And it was about a patient who was going in to see their palliative care physician. And the palliative care physician went through the regular, checklist of things. But her friend was with her, and the patient had mentioned to her friend that she was seeing this little Mexican man in a hat. And that this was probably to most of us not something that we could actually see, that only the patient could. So, from a clinician's point of view, we'd call that a hallucination. But the fact was that her friend was there with her, and that hadn't been mentioned by the patient. So the friend was able to say, well, what about the little man in the Mexican hat? And then the palliative care physician sat down, slowed down, took his time, and just listened to the story, and was able to frame that for the patient and the patient's friend, that was actually a normal thing, but it was a significant change in her disease process. But the fact that he sat down, took the time, and allowed her and them to tell their story the way they needed to was really helpful.
That it needs to come from leadership and to embed it in all structures. So we talked, some of the folks around our table actually come from organizations that have dedicated positions that are focusing on patient engagement. We talked about advisory councils, the role of patient advisors, the value of having patient and family input on things like quality and patient safety. And then we also talked about the evaluation piece, which I think is interesting, and how do we do that? And we talked about some of the typical things organizations do, such as your patient satisfaction survey, and we know what those types of information can give us, but also how do we get more of that experience-based feedback that will help us know if we're moving in the right direction?
And one great strategy, I think, too, that was talked about, and I saw on a poster over there, was the post-discharge phone calls. Yes. To encourage that follow-up, solicit that thing, let them know that we're still thinking about you, we're still caring for you, that we just didn't release you back into the wild with no care.
That the whole hospital as a team needs to be on board, and it needs to come from the top, from leadership, and it's not about pecking order any longer, because at some point we're all going to be patients and we want to be part of this system. Another challenge we thought about was how to communicate PFCC to the entire hospital staff and also to the community, to make the community aware of what is going on. Another challenge would be holding people accountable if they're not sort of following along with PFCC, and then how to change hospital policies and procedures, which can be a long journey.
If you're worried, don't call, just come. Just come and tell the receptionist that you need to see me today because there's something very important, and we will make time for you. And that costs nobody anything. That just tells me that I'm valued as a patient, that my worries are not unfounded, or that he would make time for me anytime that I needed it. Now, having said that, it's been 6 years and I've never once just showed up in his clinic, but knowing that that was an option made every day continues to make a world of difference in my patient experience.
We had one patient in our working group contributing to the work. And at a certain moment, she said, well, I think we need to have an entire section in this document that explains what patients and families go through when an incident happened, from the beginning until the end. And more than that, we really need to create a checklist that providers, when they schedule those meetings with patients and families, know what to do. And that working group member brought a group of 5, 6 other members, and they wrote the sections, we put them in the document, and of course at the end we shared the document with everybody. And Sabina, who is a mother who lost her toddler child, or even younger than that, read the piece that actually she helped writing, and she said, "Thank you for writing that. This brings me back a piece of my heart. I wish something like this was in place when my daughter died." And little quotes like that makes everything that we do worthwhile. We were able to give Sabina a little bit of peace, and we recognize how hard it is for patients, and we hope that everybody who reads that document will feel the same as Sabina, as well as us care providers will understand what patients go through and engage them even more. That's my story.
Sometimes they're reluctant to speak up because they don't want to sound that they don't know what's going on, that they don't sound intelligent. And from the staff perspective, the fear of losing control, which is, as we know, a very significant barrier. We talked about conflict of interest and keeping the voice free of influence. And so we had a bit of a discussion about whether advisors in our facilities were paid positions or were they volunteers, and how did that work? There was also a concern that patient and family-centered care can become just a phrase. It can be overused, like the word participation. And so we discussed that a little bit about how participation needs to be at all levels, and we shouldn't be paying lip service to the word participation.
We had a few, but a couple have already been mentioned. One was language barriers. If we're including the patient and the family, we always don't have somebody who can translate, so it's hard to get that information sharing. So that's a bit of a challenge. The critical thinking routine is always easier, but then you have moving outside the box, doing something that isn't part of the norm for continuous improvement. So those were two.
Any other ones? Okay, great. Thank you.
The only different one I'd add, and we had a good discussion about it, is we do tend to think of the worst case scenario. So when faced with change or challenging our own mental models. So the example was opening up visiting hours. Opening up visiting hours, the place will be overrun. Remember Mrs. B's daughter? She was here 24/7. You couldn't get anywhere near Mrs. B to provide care. We cannot open up visiting hours. So that tendency to think of the worst case scenario that substantiates the reason not to change is a bit of a challenge.
We've recruited PFCC champions, send them to, we had a group go to Annapolis last year to the IPFCC conference. We just had to Annaba. This year we sent a group to Annapolis. And we've also introduced a champion check-in program and developed a passport. So we have champions that have been recruited, and a champion becomes a mentor, an agent for change, and they have to go through the toolkit and kind of accomplish a few things that they're needed to complete. Then they become certified as champions, and they have a passport, and that has really taken off. The other thing that we've come up with is champion check-in. So every 2 weeks, we have a half-hour session where we come together as champions or new people that want to become champions. And it's mainly a storytelling or sharing session. And I'm sure most of you have read the Privileged Presence book, but we are now telling our own stories, good or bad, and that has really gained momentum. Okay. We're also coming up with a service excellence model. So hopefully in the next couple of months, or we'll come up with a service excellence model, service recovery kind of model. We've come up with clinical trials. Mary Lynn, correct me. In the next few months, we'll be working on a couple of pilots. So in our OR, we're working towards removing barriers that prevent willing parents who, for example, want to be with their children while they get anesthesia. Barriers that prevent parents that want to be with their kids. We are talking about visiting hours and a couple of other pilots. And we're doing the pilots, we will evaluate them, and then maybe implement them, hopefully implement them system-wide.
St. Michael's Hospital, which for anybody who doesn't know is a hospital in downtown Toronto, extremely busy, serving a lot of very marginalized populations, struck specifically for community advisory panels to focus and hear the voice of their homeless population, their mental health population, their Aboriginal population, as well as their women and children's, to inform both their patient rights and responsibilities, but also as an ongoing touch point to have a connection with those particularly marginalized populations. Kingston Cancer Center, in the recent development of their model of care, their redesign process, their patient advisors were involved from day one. And as they move to implementation, some of their patient advisors are actually co-chairing a couple of the implementation committees or implementation working groups. And lastly, from my home hospital, RVH in Barrie, in our cancer program, they developed a well breast follow-up clinic that's run by our nurse practitioners. And what this is that women who are technically done their treatment but aren't ready to leave for whatever reason, maybe they're just not ready to let go, or maybe our providers aren't ready to let go, the patients transfer over into the well breast follow-up clinic. But the key is the patient decides how long they stay, whether they want one follow-up appointment or whether they want 10 follow-up appointments. So it's driven by their need and their readiness to move on, feeling that they have enough information to be moving back to their family practitioners. So a couple of good examples from our table.
So lots of exchange of knowledge and information and strategies this afternoon. And we're fortunate because the white paper will be coming out and the multimedia white paper. So we're going to have the opportunity to continue to see and to learn from today and from last night. I'd like to thank Bernard and Rosalind, Gary and Holly, who are here from Georgia Regions Medical Center, for joining us today and for sharing their wealth of knowledge and their experience on their patient family-centered journey over the last 20 years. And that anytime you get an opportunity to learn from them, please take advantage of them. So thank you very much for coming up and joining us.